Good afternoon, prominent speakers, distinguished guests, colleagues, students, and friends. I am Zoe Chen, a Year 1 student studying the Global Health and Development Program at the School of Public Health, the University of Hong Kong. On behalf of the school, I welcome you all to the Hong Kong U SPH Public Health Forum 2024 on past, present, and future of public health. As you may know, the School of Public Health is celebrating our 20th anniversary this year. This forum represents the highlight of our celebratory events. Thank you all for joining us on this special occasion. To begin with, let me share with you logistics on today's program. We will start with a keynote speech on risk-based early warning surveillance for emerging diseases, followed by an enlightening lecture on non-communicable diseases. During the intermission, please be encouraged to visit the student poster session outside the foyer, where we received 44 poster submissions from our research postgraduate students this year. After that, we will continue with an engaging lecture focusing on infectious diseases, followed by a thought-provoking plenary session centered around primary health care. Lastly, we will present awards for the mascot nicknaming competition and the Best Student Poster Award. Here I share with you 2 QR codes. The one on your left will direct you to the forum webpage with information on today's program, speaker's bio, and presentation abstracts. The one on your right allows you to leave your questions for the speakers. Some of your questions will be selected for the Q&A sessions. Without further ado, let me now invite Professor C.S. Lau, Dean of the Li Ka-shing Faculty of Medicine, to give the welcoming remarks. Professor Lau, please.
Thank you very much, David. Our invited speakers, our colleagues, staff, students, friends, and guests, ladies and gentlemen. We are speaking amongst friends, so I will make this kind of informal. My very simple message in the next few minutes is one that of thank you. First, thank you for inviting me to share with you a few minutes here. And I have always said to colleagues that if I have a second career life, I would probably not do rheumatology. Those of you who don't know me, I'm a rheumatologist. I would have picked either public health or family medicine, because I actually strongly believe that a more global perspective, a more preventive perspective of disease is as important as understanding the molecular basics of an immune cells, say what I spend much of my time on in managing patients with rheumatic diseases. So if I actually retire and I actually manage to find time to apply for the Master of Public Health course, and if you then admit me as a student, I will thank you again. So that's the second thank you. The third thank you is really to thank the School of Public Health for having done so much for the faculty and the university, and indeed for the whole of Hong Kong and beyond. Although you are supposedly celebrating the 20th anniversary, as we just saw earlier on, indeed, colleagues from the school past and present have contributed to the health of the community for many, 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 many years. Way back to 1887, when the College of Medicine for Chinese actually was inaugurated, that the founding dean, Sir Patrick Manson, introduced what community health or community medicine was about to Hong Kong. He actually stressed the importance of maintaining basic hygiene in preventing infectious diseases, maintaining nutrition in preventing many different forms of diseases, etc., etc. And over the years, you have evolved from one that has not got much identity, just being part of Sir Patrick Manson and others, etc., to the Department of Social Medicine in 1950. And I found out later on that, in fact, 20 years later, you didn't actually only concentrate on social medicine, but also in preventive medicine as well. So the department was actually renamed the Department of Social and Preventive Medicine. And very shortly afterwards, we realized that it was all about community health and hence the Department of Community Medicine was established in 1974. And it has taken you 30 years, but during these 30 years, you have done so much good work that the university realized the importance of really transforming you from a Department of Community Health to that of School of Public Health. And over the last many, many years, you have done so well. You are really one of the jewels of the crown of Hong Kong U Medicine. You have been, one of the most successful units in attracting donations. You have been, more importantly, one of the key units in really securing competitive research grants. And very importantly, as we saw earlier on, many of you actually published very widely and quoted and cited very widely. And so many of you being the top 1% researchers in the world. So I thank you. Thank you for contributing to the success of the faculty and the university. And more importantly, much of the work that you do also contribute to the health, not just the academic achievements, but the health of the people. Your work on smoking, your work on the various infectious diseases, your work on mental health in Hong Kong have really, made the local government reconsider many of the health policies, and indeed have changed the health policies, particularly in the last few years during the COVID pandemic. The work that you have done have not only changed the policies of how COVID should be managed locally, but also globally. My third thank you is, of course, the organization of this program, of this symposium. And I've looked at the program. I've looked at some of the posters earlier on. You're stressing not only on just COVID or influenza or other infectious diseases, etc., but the very wide and broad spectrum of what community health is about. And I've looked at the list of invited speakers, very renowned speakers, and I thank you for organizing this. My last thank you is really to thank the school for, not just the last 20 years or the last 130 plus years, but for really working towards the future. I have regular meetings and sharings with Professor David Bishai, your school director, on how and where the school should move. And without preempting him, I won't actually talk about my sort of non-public health perspective of what the school should be doing. He will be sharing, the vision with you later on. And perhaps the last thank you that I would like to say, and that is to thank you all for coming and to thank our invited guest speakers for, visiting Hong Kong, visiting the faculty and the School of Public Health, as well as those. I understand that there will be some speaking from far away, despite the difference in the time zone. Could be very, I think for some could be nighttime and sort of bedtime for them now. And despite that, they are going to stay up and share with all of us, the wisdom. And I hope very much that you will all gain what the school intends to provide you. A lot of food for thoughts, naturally, at the end of the conference. And lastly, congratulations once more to the School of Public Health on the 20th anniversary. Thank you.
Thank you, Professor Lau, for the welcome remarks. May I now invite Professor David Bishai, Director of the School of Public Health, to come forward to share with us on the 20th anniversary of the Hong Kong U School of Public Health. Professor Bishai, please.
Thank you, Zoe. It's so great to be here. We're past, present, and future. I want to start with the present. This present moment is really all we ever have. Go ahead and take a deep in-breath for 3 seconds. 1, 2, 3. Out-breath. 1, 2, 3. That's the present moment. And it combines the past and the future. The present is a bridge. And for the next 6 minutes, I'd like to tell you about the bridge of our School of Public Health, building on the past and going into the future. As our dean has mentioned, we go back much longer, back to the founding of the College of Medicine for Chinese in 1887. These gentlemen, James Cantley, Patrick Manson, and Sir Ho Kai, were really practicing public health. The first two with microscopes to make foundational discoveries in filariasis and leprosy. And the third, Ho Kai, was a doctor-lawyer who was working on social institutions in Hong Kong and the social determinants of health. And I have to believe that our illustrious alum, Sun Yat-sen, brought in some of that philosophy into what he brought to all of Asia. So that's our long ago past. 1950, as CS has mentioned, we had a Department of Social Medicine, community medicine departments. Prior chairs, I'd like to call out, many people contributed to the 20th century history of this school. Richard Fielding is still an honorary faculty member of our school and still teaches. Tony Headley was a mentor to so many of us. I wanted to show you his picture because he contributed to the battle against tobacco, and the Headley Environmental Index is still used in environmental health. So we stood on broad shoulders as we launched into the establishment of our school in 2004, when we became a School of Public Health. This photo is a visit from the visitors from the Health Department, the Ministry of Health of China, who came to start an MOU. And you'll see in the front row is the Minister of Health himself, Professor Chen Zhu, consolidating our establishment. We launched our Masters in Public Health in 2004. This class that you see pictured in 2005 has Professor T.H. Lam in red at this side of the picture. T.H. Lam couldn't join us today due to travel, but he sends his regards. What was on their minds in 2004, 2005? I think many of you know. They were thinking about SARS, and they had just emerged from SARS, and the faculty were thinking, how do we prepare and protect Hong Kong and Asia against another pandemic? Well, that paid off, and we'll be hearing about that soon. They also knew that they had to collect data on the health of the people of Hong Kong. And so cohort studies came one after another, and we have that legacy still today guiding a lot of our science. The family cohort, the elderly cohort, the cohort of 1997, and I see here colleagues, Ryan Aoyung, Jane Jie, and Michael Nee, all working on this cohort approach to public health in Hong Kong. The Hong Kong U Pasteur poll came along in 2013. It's still a vibrant part of our scholarship, giving us access to colleagues from around the world, informing us and drawing the best talent in infectious diseases to our campus. We became a WHO collaborating center in infectious disease epidemiology and control in 2015, and that really paid off for us during the pandemic. It enabled us to really live out our potential to help prepare our colleagues for this pandemic. We have 3 theme-based research projects that help us do translational research and connect our scholarship to policy. Led by Malik Paris, we have a viral host and environmental determinants of influenza, another control of influenza, thematic research project by Professor Ben Cowling and Professor Leo Poon, who has one of these theme-based research projects on COVID-19. We translate knowledge all the time for local communities, and you could see some of these initiatives that we're doing to reach out to the people of Hong Kong through our breast cancer study, our gender and COVID-19 studies, and the Headley Environmental Index is still an important contribution to knowledge exchange. In 2019, our school started a Bachelor's of Science in Global Health and Development. And you see pictured here, right on that side, is my predecessor, Professor Keiji Fukuda, who was the director of the school from 2018 to 2022, who helped to found this important degree, which led to our first graduating cohort just 6 months ago in the Global Health and Development cohort. Well, for the last 4 years, our faculty have been really contributing so much to the control of the pandemic. And we've been in touch with WHO, with the governments of Hong Kong and around the region, making breakthroughs on documenting the spread of the pandemic. The photo in the middle is interesting. This is a research subject proving whether or not masks help reduce transmission. And in 2020, Professor Ben Cowling was able to give some evidence to the use of masks to help control the pandemic. And it protected so many of you, protected me, and that science came from our campus. We have other knowledge translation initiatives, the Data for Discovery and Health, and the Center for Immunology and Infection, to reach out and to protect the people through new discoveries that can be applied and to change the world. Most recently, what I think will step us into the future is the Jockey Club Global Health Institute. We'll be hearing more about that later today. And here's the signing ceremony starting this, and Professor Leo Poon will tell you more about what this does for us in our future of getting the world ready to fight pandemics. So in closing, I'd like to celebrate these last 20 years. Yes, we have the top 1% of researchers pictured here, but that scholarship is not for research's own sake. What we do together is we bring out the best of each other in teaching and in application and knowledge exchange to make our society strong and healthy and to create the conditions in which people can be healthy. So happy birthday, Hong Kong U School of Public Health. Thanks for being part of this, and thanks for sharing this afternoon becoming part of our birthday celebration.
Thank you, Professor Bashai. Please be seated. Now let's take a group photo together. The photographer will be taking the photo from the stage. Prominent speakers, distinguished guests, colleagues, students, and friends, please stay in your seats and look towards the stage. Ready? 1, 2, 3. Thank you, everyone. We will now proceed to the virtual keynote speech of today's forum. The topic of the presentation is Getting Ahead of the Curve, Exploring the Development of Risk-Based Early Warning Surveillance for Emerging Diseases. May I now invite Professor Bashai again to the stage to introduce our keynote speaker. Professor Bashai, please.
Well, it gives me great pleasure to introduce our speaker on our 20th anniversary. I really want you to join me in welcoming Professor Marion Koopmanschap. She is joining us virtually from her home in the Netherlands, where she is the director of the Department of Viroscience at the Erasmus Medical Center. In addition to her work at Erasmus, Professor Koopmanschap also holds the prestigious position of being the scientific director for emerging infectious diseases at the Netherlands Center for One Health. She has produced great scholarship at the forefront of research on emerging infectious diseases and has made significant contributions in the understanding of the origins of these diseases and control strategies. Her work has informed public health policy and has inspired countless researchers around the world, and especially here in Hong Kong. She has a doctorate in veterinary medicine from the Utrecht State University, as well as a PhD in infectious diseases and immunology. She served as the chief of virology diagnostic lab for infectious diseases of the National Institute for Public Health and the Environment in the Netherlands, and has received the Stevens Premium, which is the highest award that the Dutch government offers to any of its scientists. She is a great communicator, and as a testament, she has won an award for science communication. She is a trusted voice of science, and her insights have been so helpful over the many years. And she is a great friend of our school, so I'm really looking forward to her remarks. As we celebrate our 20th anniversary, I couldn't think of a better speaker for us than our friend, Professor Marion Koopmanschap. Ladies and gentlemen, without further ado, please join me in welcoming our esteemed keynote speaker, Professor Marion Koopmanschap.
Well, good morning, and thank you very much for your kind words. And let me also congratulate you on your anniversary and the names that were mentioned. This introduction section are very well known globally. And I'm very happy to say that we've been collaborating over the years quite well and with great enthusiasm. So, and thank you for the opportunity to present some of our thinking. So this is really thinking about how we all collectively can improve our ability to be prepared for emerging diseases. And this is a presentation about the VEO consortium that I lead, which is a European consortium of 20 institutes in 12 countries that collaboratively works on early detection of possible new disease problems, because that's our focus. If you look at pandemic preparedness programs globally, they are leaning quite heavily on what to do once you have humans getting sick. But where we want to be is maybe get better at early warning by focusing on the pre-emergence stage, as we call it. And that builds from the knowledge that many of the new diseases actually arise from the animal world, and because of interactions and changing interactions between humans, animals, the ecosystems that we share, and the vectors that we share that also are present in those ecosystems. So our focus is on pre-emergence. And the key and central question throughout the VEO project is, can we get better at predicting the risk of outbreaks or disease emergence so that we can really target our efforts for surveillance? And that is important. We all know that it is important to be better prepared and to pick up diseases early so that outbreaks don't get the opportunity to be so big. But where do you focus those activities? And that's what we're trying to address. We walk through disease emergence scenarios, and these are the ones that we work with. A zoonotic wildlife-borne disease scenario. Think, for instance, about a new human epidemic through avian influenza spillovers. A vector-borne disease emergence, a scenario looking at possible effects of release of pathogens from permafrost. A scenario that we call silent epidemic, which works on trying to understand and develop early warning for spread through high density urban regions. And whatever gets done and developed really needs to feed into our ability to better prepare for any disease. So that's called the disease X scenario. And this project and the whole call that we responded to is about working with different types of data. There's huge amounts of data out there, but the key question is, can we really use that to address these questions? We're all familiar with the core public health data that is used in surveillance, for instance, with some patient-related data, laboratory data, epidemiological data, which is really the key for global surveillance systems. But what we're exploring here is what we can do with what we call contextual metadata. So data of many different types of pieces of information that help you inform about drivers for disease emergence. Think, for instance, about travel data, data about bird migration pathways. And there's lots of data out there, but of course, you have to then learn how to work with that. One key element of our work is also that we try to build tools and infrastructure that can be used and reused also when this project is ended. And that's why we build on existing infrastructure that is hosted through the European Bioinformatics Institute, which is an organization that has been funded for decades now to really build infrastructure for biomedical research. And it is connected with the NCBI in the US and the database of Japan into the global highway for biomedical data. And anyone who submits sequences, for instance, to the NCBI works with this infrastructure. Here is a part that we built in response to the pandemic when the president of Europe said we really want a COVID data portal in the European Open Science Cloud, and that's what we felt helped to develop. And the same was done and reused for Mpox. And this is accessible for anyone who is interested in seeing what data is around there. For instance, here, this is during the pandemic, we built a platform to collect, but also analyze raw sequence data. We have a very well-used portal that's called GIS8 that is used globally to collect genomic sequences of pathogens. But for scientific in-depth work, we also would like to be able to access the raw data, which then is processed through specific workflows so that you get one set of data that really has been analyzed in a standardized manner for further research, as an example of the type of things we do. But I will now walk you through two of the scenarios that we are working on, just to give you a feel for how that is. And here's the first one that is thinking about vector-borne disease emergence. We do have some vector-borne viral diseases in Europe, and what you see to the left here is a notification map from the European CDC, which shows where in Europe cases of West Nile have been reported. This is a map from 2020. You see that most of the activity is in Southern and Eastern Europe, with some pockets here in Germany and here in the Netherlands, where I'm at. And we do see other arboviruses knocking on our doors, knocking on our borders, and particularly in Southern Europe. Here, so for many years in a row now, we have a couple of cases of dengue, some local transmission. We've had occasional chikungunya, sometimes a bigger outbreak. And the question is, where will these viruses go? What does it take to increase the circumstances to get outbreaks? And for West Nile, here as a first step, for instance, we are looking at combining information on pathogen genomics with the hosts that we find those viruses in, with data on location and time, the classic data that you collect for public health surveillance, and then use that to see what is the direction of spread of this virus. Here, one of the lineages, West Nile virus lineage 2A in Europe. And what you can see in the movie here is that something seems to be happening here in this part of Europe, from where you see two directions of spread, one moving to the south and one moving to the north. And these are actually two separate subclusters of this virus lineage. And then we look at what data is out there that can really help us understand that direction of spread. So what drives the spread of this disease in this context? And for that, we construct a map of drivers. This is published here. You can, if you're interested, you can look for the publication and read the details. But essentially what this is a diagram of all the factors that can influence emergence and spread of a vector-borne disease. There is information in there like here climate variables, farming, change of land use, which is a well-known driver for disease emergence, travel to understand, for instance, people bringing in viral infections when they are viremic, not so much an issue with West Nile, presence of factor and things like that. So for each of those drivers, we look at what is out there in terms of data, how good is that data. So there is a process of reviewing the quality of the data, and then from that we select the data sets to work with. And here in this exercise, we ended up with 41 sets of data in 5 different clusters. And here are these clusters. So climate data, socioeconomic data, land use data, some topography data, which is important for vector presence and abundance, and data on species there. So then we asked the question, okay, what can you explain? So what is the correlation between this type of data and the direction of spread? And see that this virus spreads towards regions with the highest urbanization and wetlands, where both migratory birds and resident birds intermingle. And that spread is accelerated by agricultural density. So you can see how that could help us to then say, okay, let's focus our monitoring activities in regions where these factors converge. So that's what we've been doing in our country. The Netherlands is a delta and is rather fast in temperature increase, and so climate effects, which is more than average affecting our region. So guided by this type of analysis, we have set up a monitoring program and found indeed West Nile to be present in our ecosystems here, with some positives from birds and poultry and mosquitoes, as you can tell. And that then informed public health response. And then we found that indeed we already had some cases in the hospitals, and no one had really thought about the possibility of a locally acquired arbovirus infection. But you can see this is a phylogenetic tree. You can see that that virus may have been introduced not so long ago. We detected this early 2020, probably something like the year after it had been introduced. Now then the question is, of course, where else does this go? Was this a chance introduction, and will this die out? So again, guided by insights in where best to monitor, we have set up monitoring and see now for some years in a row, working with chickens at petting zoos, that we continue to have seroconversions, even if the virus itself is rarely found, and we do not have human cases as far as we can tell. We do see that this virus continues to be present, and with a recent finding of just some genomic sequence, we can confirm that the virus is staying, has not disappeared. These are not new introductions. So we have enzootic presence, yet no human cases, and there's information, public health information, that warns about this risk now. And what we're also now looking at is what happens if we work in our landscape, because this is an aerial map of our country. It looks much green. It looks very green. It is green because we have a lot of water, as some of you that visited will know. But we are also increasing the amount of wetlands, and that is to get better prepared for the climate impact that is expected and projected. One element is sea level rise. The other element is more extreme weather. And because of that, land use architects are developing new wet areas across the country. And we're now working together to see, okay, what does that do to infectious disease risk? And can we do that in a way that does not amplify that disease risk? Now, one of the types of data that we felt were in short supply is information about vectors, because they, of course, are critically important when you talk about risk of vector-borne disease establishment. And here we work with citizens and citizen scientists across Europe through the work of our Spanish colleagues who have developed apps to collect information, not only pictures of mosquitoes, but also reports of bites, breeding sites, and they also sometimes can send mosquito samples to a lab for further identification and for testing. And that is information that also now is built into the collective data history. So here is the mosquito alert image data set in the bioimage archive, which is part of this European data infrastructure, and it's open, so anyone who's interested can access it. So what this has also been used for is to help with with collaboration with entomologists across the world to help learn computer programs to recognize mosquitoes from these photos. And this is the first publication that has done that for Aedes albopictus, which is one of the easier ones I've been told to recognize. So here machine learning programs have been developed to help recognize these, to type the mosquitoes from the images, and that of course speeds up what you can do with citizen collected images. Now moving to another of these scenarios, and that's looking at urban amplification. So there are examples you can think, for instance, about polio. Polio, of course, is a human disease, which is insidious in the sense that it can spread under the radar, because for every case that has clinical symptoms, there can be up to 500 and even more asymptomatic or very mild cases. So it's easy to go under the radar. And those are viruses that do amplify through highly connected urban clusters. And that is a scenario that we call silent epidemic, where we focus here on what can you learn if you actually mine all information on a community through wastewater. This was already ongoing before the pandemic. And of course, during the pandemic, we have seen how valuable wastewater surveillance can be. So what we do is collect wastewater in countries across the globe, here in all continents. We've done that at several time points. This was work that had started before the pandemic, which of course was on hold for a while because of everyone was pulled into the national response situation, but we're moving into it back into it now. And in some cities we also have consecutive samples. So what we do here is not focus on single pathogens, but really try to learn, if you combine this with the tools that we now have that can capture any genomic information in there, how could we use that? So this is working with metagenomics to try and understand the diversity of wastewater virome and microbiome. So we divide the samples between people that work on bacteria and resistance genes, and with us working on viruses. So depending on how you do those analysis, you can catch any virus in there or enrich for the viruses that you're interested in. So this is a difference, testing the same samples, unbiased for the experts in the room, or using a capture protocol which enriches for known human pathogen. And this is then the type of information we're looking at. This is now looking at all the data in there, on all virus sequences at the species level, in a couple of cities where we have multiple sequential samples, and say, okay, what is there in common? And you see there is a central region where there's a lot of things in common, but you also see there some locations standing out. Sometimes here in the non-capture, so the broad genomic data set, sometimes in the capture data set. So then we can zoom in and look at, okay, what is in common and what makes some of these sites stand out? Can we understand those differences? And here's an example. This is now looking at some viruses that you probably have heard about, enteroviruses. If you look at just at the level of species, you can see there's enteroviruses in every site on every time point, and that makes perfect sense because these are very commonly present human viruses. But if you then move down one level deeper and use the sequence to characterize which enteroviruses they are, you see in this consecutive snapshot across cities across the world, you see very different patterns. So you can actually follow with a limited number of samples, really, the epidemiology of this important group of pathogens in different parts of the world. And you see here's a wave of one particular enterovirus, here's a wave of a very different particular enteroviruses, and here in this town in the African region, there really is no clear pattern present, and it's important to try and understand that. This is an example from another virus, norovirus, which is quite diverse. Here for one of the noroviruses, the colors now depict where these viruses have been found. And you see a small cluster here in yellow, which seem to be sitting only in the samples from the African region. So then you can actually take the sequence out of the wastewater sample information, clone that, and try to understand how that particular virus behaves. And we found that it really is unique. It has a unique receptor binding. It's very different from any of the known noroviruses that we have. So, and then, of course, you can see how to further characterize that. So these are just some examples of the type of work we are doing. And from it, we think we can actually get better at targeting our surveillance. It's all exploratory. It needs a lot of work to really validate. But particularly also, it does require a mindset change that we do not only start thinking about these diseases once people get sick, but that we really consider us humans as being part of a much wider ecosystem that we share with animals and with viruses, and where it's really important to understand that the health of all of these components of animals, of the environment, and of people is tightly interconnected and needs to be studied conjointly. So with that, I would like to really thank the VO consortium. It's a fabulous consortium. Professor Paris has had some experience, and of course our funders that make it possible to do this work.
Thank you, Professor Koopmans, for sharing. We will now proceed to the Q&A session. Audience may scan the QR code on the screen to pose a question. Professor Malik Paris, Chair Professor of Virology of SPH, will be the moderator of the Q&A session. May I now invite Professor Paris to the stage, please.
Hi, Marianne. Thanks very much for that, for getting up early, because it must be about 7 or 8 in the morning for you, and for that great talk. While waiting for questions, you really highlighted the importance of looking upstream. I mean, not just waiting for the epidemic to start before intervening, but if you look at a lot of the focus at the moment, whether it be the pandemic fund or even the pandemic treaty that is being now negotiated, a lot of attention is on the downstream, the vaccines and other interventions. So how do we get more attention placed on this upstream prevention of spillover?
Well, yes, that's I was hoping you could tell me. I do think it's really important, and I do agree. If you look at all the investments and the efforts, they are what I consider reactive. I'm not saying they're not very important. They are, and we've seen how important they are. And just this week, the new 100-day mission was published, which really focus on, well, how can we very rapidly speed up our ability to develop vaccines, for instance, as soon as we know of a new pathogen. But it is clear that we need advocacy to also invest in understanding where these diseases arise. There's many examples of reviews after outbreak reviews where you see the same patterns over and over again. We see big changes in an area where, in retrospect, say, well, you could really see this coming. And that's the information that we try to capitalize. And I do think we have to continue to advocate for the importance. Now, having said that, it's also not easy. It's easy said, and it does make perfect sense to focus on pre-emergence. But of course, what we need to learn, there's also a risk of many false alarms. And what we need to learn is how to do this better and how to move from the research into something that is actually actionable, also for public health activities.
Yeah, thank you. So there are some questions that have come in online, well, from the audience. So one of the questions is, how would climate change impact our strategy for pandemic preparedness?
So climate change is, of course, a well-known driver for disease change, and it's not a simple one-on-one direction. There's a very interesting systematic literature review done by the University of Hawaii that has taken apart all sorts of aspects of climate change. There's temperature increase, there's increased severe storms, there's of course sea level rise, and for every element of change, they have looked at what does the literature tell us about direction of change for pathogens. And you can see that literature does suggest increased risk for many pathogens. If you look at viral diseases, a lot of that is associated with vectors, where vectors are, where what climate change does to the ecology of vectors. For bacterial diseases, a lot of that is related with waterborne and foodborne disease. So the impact can be very different, and it's a complex picture.
Right. Let me get in. Well, the second question is also very similar. It's regarding climate change. Yeah. So then we have a final question, which is somewhat controversial. If we continue to search for viruses in wildlife and studying them in biosecure laboratories, are we more likely or less likely to have another pandemic in the next 10 years?
Yes, this is addressing the risk and maybe also a bit of the discussion of what happened at the origins of some of these outbreaks. Yeah, of course you have to be wise about it. I'm not advocating just random sampling, testing, and going out, but really using a well-designed strategy to say where are the risks greatest, and then you can see how to collect data, what to collect, and how to work with that samples. I mentioned, for instance, our Greenland expedition. There's a link, I will send the slide, for a movie about that, where we really think about that. We really want to understand what is there. We also don't want to increase risk and bring things back to laboratories. So it is about a thoughtful process of what are the questions, how important are they, what are the risks, and what do we do to mitigate those? And with that, I do think it's really important to do biosurveillance studies.
Thank you very much, Marianne. We have run out of time, so thank you again.
Thank you, Professor Koopmans and Professor Paris. Professor Koopmans, wish you a good day. Professor Paris, please be seated. We will now proceed to the lecture on non-communicable diseases on the topic, the role of the University of Hong Kong in overcoming obstacles to non-communicable diseases control. May I now invite Dr. Judith McKay, Honorary Professor of SPH, Director of the Asian Consultancy on Tobacco Control, Senior Policy Advisor of the World Health Organization, and Honorary Consultant of the Department of Health, the Government of the Hong Kong Special Administrative Region, to share with us. Dr. McKay, please.
Congratulations, first of all, to the School of Public Health on its 20th anniversary, and thank you to Professor Bichal for inviting me to speak today on non-communicable diseases. I've been in Hong Kong since 1967 and have a long history with the university, first of all in clinical medicine, and then in 1984 realizing that public health in Hong Kong would never be solved by curative interventionist care, and therefore moved into public health, particularly tobacco control. So I'm using tobacco control today as my sort of basis for the lecture, but it does apply to many other industries, to many other non-communicable diseases. I'd like to, first of all, speak about some of the obstacles to NCD control, and these are found in Hong Kong, but they're also found globally. Everywhere in the world, there is this focus on curative medicine, not prevention. Everywhere, the traditional pattern of, this is intervened. The traditional approach to sickness and to health is not suitable for NCDs. There are a lack of funds for research and intervention. There's a surprising lack of involvement by health professionals. There's a lack of awareness of the scope of the harm. 60% of our deaths now in the world are caused by non-communicable diseases. 2/3 of smokers die from them. Absolutely extraordinary. There's a reluctance to interfere with personal behavior. There's a preoccupation with other illnesses and other issues, and that can range from COVID to warfare, in fact, in different countries. There's misperceived economic concerns that, for example, if you raise a tax on tobacco, that the economy will suffer. There's all the advertising, promotion, and sponsorship that come from many industries, not just from the tobacco industry. There's no real understanding of the environmental consequences of non-communicable diseases. But the biggest opposition that we face here in Hong Kong and we face in the world is the tobacco industry. Its promotion, its distortion of health, its pseudo-economic evidence, its financial might, which is extraordinary, greater than the GDP of many countries, challenges and threats to government and front groups, and all of these we have seen and need to counter in Hong Kong. Hong Kong University has a long history of rebutting the tobacco industry tactics, and I just lay some of these tactics out here. And for those of you who think that this slide might be slightly extreme in its presentation. This slide was produced by World Health Organization, which is certainly not a radical body, it's a very conservative body. So for WHO to present the threat to public health with these kinds of images, I think is an indication as just how bad the problem is. So what does the tobacco industry do that we and the university with the government in Hong Kong need to rebut? They maneuver to hijack the political and legislative process seen here in Hong Kong. They exaggerate the economic importance of the industry. They manipulate public opinion to gain the appearance of respectability. They fabricate support through front groups. They discredit proven science and economic evidence. And they intimidate governments with litigation or the threat of litigation or trade threats. I'll give you some practical examples of this. In Hong Kong last year, the year before last, we banned new tobacco products, the e-cigarettes, for example. So what exactly happened with the industry? They attempted to create heated discussion in the media. They bombarded government with a template, letters of objection. They smeared the health minister on all fronts, and these quotes are actually coming from inside the government itself, which is recognizing just what was happening while this was going on. A Why Not Regulate Hong Kong campaign was launched by the Vape Shop Hong Kong with posters and banners all over Hong Kong. Philip Morris threatened to shut down Hong Kong facilities if the ban went through, stating it would cause unemployment in Hong Kong. And during the bill's scrutiny, the tobacco industry bombarded government with legal documents, questions, accusations from lawyers, which ate up staff's time and energy. Industry-friendly legislators also asked multiple difficult questions that required government to answer and provide details and translation. These tactics, according to the government, exhausted the government staff, making the process of bill scrutiny very painful. Several legislators openly support the tobacco industry, including one who brazenly said in LegCo, "I am the voice of the tobacco industry in LegCo." And one veteran lawmaker in Hong Kong told me that he had never witnessed the intensity of lobbying in LegCo on any topic, not tobacco, not just health, but any topic in the whole of the history of Hong Kong. So this is the kind of tactics, in a sense, that we have, as public health people, have to basically counter. There are also industry front groups in Hong Kong. Now you can see at the top there, youth smoking prevention. How nice does that sound? Everybody wants youth smoking prevention. But who is running that? Who is funding it? It's Philip Morris. It's the tobacco industry. It's a front organization to try and gain respectability and acceptance in Hong Kong. And then there is the Tobacco Control Concern Group, which is several retail groups and tobacco companies who have come together to try and challenge government on everything they try to do, almost particularly taxation, but to challenge government on everything they try to do in terms of public health. And perhaps rather worrying is that the TGCCG actually includes newspaper and magazine merchants as well, and that makes it particularly difficult to get the real story of tobacco sometimes into the press. And the tobacco industry support and its supporters monitor and attack individuals, and Hong Kong University has certainly seen its share of that. They have described me, and actually I'm quite proud of some of these names that they've called me: sanctimonious, dogmatic, pontificating, meddlesome, heretic, puritanical, hysterical, prejudiced, a nanny, a psychotic human garbage, and on it goes. If you worked in public health, particularly in the early days, in the 80s and 90s, you came under considerable attack from the industry. It's not in the past alone. In 2016, I was on RTHK, and someone from the Lion Rock Institute said I was a jihadist. I was the ISIS of anti-tobacco. If tobacco was America, she would be ISIS. She's willing to spread this war globally. There is blood on your hands, Dr. Mackay, they said on live radio in Hong Kong. I've been threatened with court cases and death threats, one from America that was investigated by the FBI, and on another occasion offered 24-hour police protection by the Secretary for Security in the Hong Kong government. Many of you in this School of Public Health may remember in 1989, there was a very costly court case brought against a Hong Kong U public health doctor in this department who was researching passive smoking. And it was just at the time that 3 Hong Kong U researchers, including from this prior to the School of Public Health, including that department, who were found to have been recruited by the tobacco industry to argue that passive smoking was not harmful. And as we've heard, even government officials were smeared in 2022. I've mentioned it's not just tobacco. This is an example how the food and beverage industry have attacked research, attacked policy, attacked adoption, attacked implementation of public health law. And any of you working or hoping to work in public health is going to have to address this and to counter this at every turn. It has got so bad that WHO have just produced a new unit in Geneva in its headquarters on unhealthy commodity industries. It's got as bad as that. So that's the scene. So what has Hong Kong U been really able to do about this in terms of solutions? I would first say we already know what works. We know from research here in 41 countries, the taxes, the smoke-free, the warnings, the cessation, the marketing bans, all of these are effective. But actually we also know from research done, not by Hong Kong U, but in fact by the tobacco industry itself. And this is called the scream test. If the industry screams and tries to oppose a measure, we know that it's going to be jolly effective. And what do they scream at? They scream at tobacco tax, they scream at smoke-free areas, bans on promotion, the plain packaging, and on the new products, particularly the latter at the moment. And if they ignore a measure, we know it's probably useless in terms of public health. Those are the traditional disease-based school education programs, telling 11-year-olds that they will get cancer when they're 70, and a ban on sales to minors. So in some ways, our research is done for us by the industry itself. Now, what should we be doing? The model sequence, as all of you will know, is to go from research to evidence to persuasion of governments to government action. And if you do this nice sequence here, you get a little converging circles up at the top of a successful policy. And all I can say is, if only it were that simple in Hong Kong and elsewhere. There are many obstacles for scientists, such as in your school, to turn your research into policy. But you can use research to lobby for governments, for government health policy. But it is a new art and science. And not everybody who is very happy doing research projects is happier challenging, for example, the industry and dealing with governments. Very few medical schools in the world teach health advocacy, communicating research findings to influence policy. Putting your article in an academic journal might reach perhaps 1,000 people, most of whom will probably agree with you. You have got to learn to use the public forum and the media to try and influence policy, because after all, what is research for? It's only really to try and influence public policy. Universities accredit researchers' publications, but universities do not give time, do not credit really the time and effort spent on publicising findings, utilising them for public health policies. Holding a press conference or giving out press releases does not actually earn you many credit points on your CV. And also it's very difficult for researchers and universities to claim credit that their one research paper has produced a particular policy result. And I'm reminded of the saying of the Zen poet Ryokan, in this one bowl there is rice from 1,000 households. And that's exactly how public health policy works. In Hong Kong, it's research from the Hong Kong universities, from other universities, from the government, from the Council of Smoking and Health, from researchers, from many different people contribute. So it's very difficult for a university to say, well, we claim credit that we had a good public health policy in Hong Kong, because there is rice from 1,000 households. But health researchers can influence policy making. They can identify, to start with, the critical problems, prevalence, harm, and costs. Economic evidence is much undervalued, and yet it's economic evidence that governments listen to. They say, yes, yes, we know the harmful effects, but they're more interested, in my experience, of making sure that it doesn't undermine economic policy of the government. Framing research with the goal of policy change I would go as far as to say that all research should be policy driven. It should be geared towards doing something about the problem that you're identifying it. Research the efficacy of policy solutions. We've only just started now to try and look, what is the effect of raising tax? What is the effect of a particular pack warning, for example? And participating in that policy process to aid real-time decision-making. And that can range from the use of media to political lobbying and to expose tobacco industry tactics. Hong Kong University has these are just a few papers out of hundreds, I would probably say thousands actually, over the years that this school has come up with in terms of health in Hong Kong. Even in tobacco control alone, there must be hundreds of papers now have emanated from this university. The action of doing this is really important because there are many things that only governments can do, and that's why we have to engage with governments. Passing public health legislation, laws, only governments can pass the laws. Only governments can implement a tax policy. Only governments can ratify the conventions. We have one in the world only, up to now, the Framework Convention on Tobacco Control. There is another being negotiated, as we heard from the previous talk, on pandemics, but at the moment, the Tobacco Treaty is the only one that WHO has got. Mobilizing resources, coordinating interagency responses, only governments can actually do this. And just again, as practical examples, what did Hong Kong U do in the whole campaign to try and ban these new products before they got on the market? There were seminars with local and international experts. Hong Kong U was there, as you can see at the top. Press conference and press releases, media debates with the industry. There's me sitting on a couch with somebody from Philip Morris debating this whole issue on TVB. Rallies outside LegCo, lobbying LegCo members, presenting the research, a signature campaign run by COSH, youth survey done by Hong Kong U, a parent survey, teachers' organizations, we do not want these unknown new products on the market, countering the industry claims and utilizing the Framework Convention, as we've heard before. And Hong Kong U was intimately involved with all of these processes in order to get successfully a law to ban the products. And here you see outside Legislative Council, I wouldn't call it exactly a demonstration, but lobbying LegCo members as they were going into LegCo. And you'll see at the top here, I've just shown a paper from LegCo, and it's very interesting how often these LegCo papers do quote the research from Hong Kong University. So the research you're doing here is being utilized, not by accident, it's being utilized because of the persistence of people working in tobacco control, like T.H. Lam, like Daniel Ho and others, of getting their research to the government and to the legislators so that they can make good public health decisions. Also, many conferences and boards, such as a conference today to spread the word. And also you'll see at the bottom right here, we have one tobacco control journal, which is published by the British Medical Journal. And there again, you see a representative of Hong Kong University on the board of that particular journal. And it's equally important to go into the public and media engagement, as I've mentioned, with press conferences, getting into the press. I was the first executive director of COSH in 1987 for the first 2 years, and we had a maxim that if we were not on the front page of a newspaper at least once a week, we were not doing our job properly. We had to get the message out. So what are the lessons learnt in Hong Kong? That the industry is a formidable opposition. I've also learnt, because I've worked really in virtually every country in Asia. I've had 3 visits to North Korea, for example, working there with the government on tobacco control. In spite of all the differences between kingdoms and democracies and size and GDP, this is the same product, the same harm, the same things need to be done, the same obstacles. And actually that's a good message for the young ones amongst you in public health, that if you work in public health, you will have a passport for life to work in many countries in the world. And also, although people might think that we're doing well with the tobacco epidemic, you will still have a job for life. But we do need that sound data on prevalence, health, economic and policy effectiveness. And perhaps I'm a case in point, you need decades of persistence. I've been working now for more than 40 years on tobacco control in Hong Kong. But we will never be successful unless our vectors in terms of non-communicable diseases are vectors of the industries, like the tobacco industry, unless we understand and address them and do research on them. In Hong Kong, one of the things that we have to do looking for the future is to set an endgame target. Public health has not been very good in setting targets, and governments don't like doing it because they feel if they don't reach the target, they'll be criticised. But the reality is we've started doing this, and in tobacco, you can see here, there's a list of countries. Hong Kong is on the bottom. Our prevalence now here is in single figures, which puts us with a couple of other countries in the world, a couple of other locations in the world only that has a prevalence in single figures. But we have made, the government has made a commitment to get that figure down to 7.8% by the end of next year. So one challenge for the School of Public Health is how are we going to do that? How are we going to actually get that prevalence from 9.5 to 7.8 within less now than a 2-year period? That really is a major challenge for the school. Do we need to consider new ideas? We need to do more of the same, for sure, in terms of implementation and putting up the tax. We have had a few new ideas in the world over the last decade. There is now a coordinated global project to monitor the industry. It's called STOP, the STOP project. And they publish every year indices showing the kind of way that the tobacco industry is interfering in countries, at least exposing what's going on. Tobacco-free portfolios is very interesting, encouraging big investors and banks things like AXA to switch to tobacco-free investments. They have had some discussion with the HSBC, but they haven't yet committed. A tobacco-free generation where any young person born after a certain date will never be able to buy cigarettes, and that's being considered here in Hong Kong. At the moment, at this very moment, there is a plastics treaty being negotiated, and it has brought us together with the environmental groups for the first time, to tell the truth, in history, because the cigarette butts contain single-use plastics. And considering the billions of cigarette ends that are actually discarded every day, this is a major impact on the environment. So we have become very much part and partner with the environmental people in terms of the negotiations of the plastics treaty, which is under UNEP. One other idea that started with John Hopkins and has been brought here by your professor is to ask other schools of public health to take action on tobacco control. The response, for example, in China has been, I really, to tell the truth, could not identify a school of public health in China that has really taken up the issue of tobacco control. And remember that 1 in every 3 smokers in the world lives in China. So this is a major challenge for China. Yet I don't know of any of the public schools that have really even sort of come out publicly and acknowledged and taken any action on tobacco control. And Professor Bashal, I know, is interested in this. So apart from what we know works, we also need some innovative thinking, some light bulb moments as we move to the future. So finally, and here's me practicing my Tai Chi, which I understand from one of the posters upstairs is really very healthy, that the tobacco and other unhealthy commodity industries will not stop interfering with policy. Academia has a vital role to play. They can expose and counter industry interference, but to tell the truth, at the end of the day, it's a government that has got to put a stop to it by adopting transparency measures, refusing to meet with the industry, to follow the Framework Convention, which has one very specific clause, 5.3, that the tobacco industry has no place, no seat at the table in terms of discussing public health policy. And that should really be applied to all of the unhealthy commodity industries. Thank you.
Thank you, Dr. McKay, for your sharing. Please be seated for the Q&A session. We will now proceed to the Q&A session. Audience can pose a question using the QR code. Professor Daniel Ho, Associate Professor of the SPH, will moderate the Q&A session. May I now invite Professor Ho to the stage, please.
Thanks, Judy, for this most excellent talk on NCD using tobacco as an example. I'm glad you also raised the importance of advocacy in translating our research findings into practice, into policy. Actually, I think the number of threats you receive from the industry is the best testimonial of how important your work is. All right, I've got some questions here. First one, do you reckon that marketing mandates, such as printing smoking vests and photos of the effect of smoking on cigarette packs, are effective deterrents?
I think it has been well shown that pack warnings do have an effect upon smokers, not so much on young people who are not yet smokers, but certainly on smokers. And in Hong Kong, we started in the early 1970s putting a text warning on, smoking is harmful to your health. And then we realized that we had to go much further than that, even at the beginning, because what the tobacco industry did was they put the warning on, but it was like grey on a lighter grey. The characters were so small you could hardly read them. So from that day on, we've had to update them all the time. We moved into pictorial warnings some years ago, and now really we're looking at plain packaging where virtually the whole pack is a warning. And yes, smokers do notice them, and they've done research, for example, in China as well as in Hong Kong to show that they do have an effect upon smokers. There's no one single magic bullet to get a smoker to quit. It may be their child comes home from school, it may be that they've got a health threat, they've got a cough from flu that doesn't subside, their workplace goes smoke-free, they read an article in a paper. There's many things that will influence the individual smoker to quit, but good pack warnings are part of that.
Right, if you can do three things, three policy changes for tobacco control, what would you suggest? Tax,
tax, and tax. I think it's as simple as that. It's shown throughout the world that if you put up the price of cigarettes, not only does it encourage older smokers, and particularly the poor, to quit smoking, but children can't afford it. It's as simple as that. That if you had one thing to do, and it's interesting because it's not exactly a health measure, it's a fiscal measure, but if you put up the price, you put it out of the range of children being able to afford it. And as we all know, your frontal lobe matures when you're about 23, and that's the time you start making long, sensible life decisions. So if you can prevent children from smoking until the age of 23, they will not start smoking after that. And we know around the world the average age of starting smoking is well under 20. So the price, what it does is it prevents children, it's an affordability issue, it prevents children being able to buy them.
The audience might know that New Zealand and other countries have been most ambitiously raising new policies, including tobacco-free generations. But then in New Zealand, they reverse it. So the one question is that how can we avoid something like this happening in Hong Kong?
I think with tobacco control, as I said in my talk, there is no quick fix, and we have to just pursue it. People sometimes ask me, why don't we just ban smoking? But prohibition in the US regarding alcohol just led to crime and corruption. So every government around the world is just pushing back the frontiers with all of the measures that we've described, and the new ones as well, pushing back the frontiers. And the truth is that if you get a 1% decrease in smoking a year, you're doing pretty well, which is why it's a real challenge for us to get an almost 2% in the next 2 years. We have to do well in the next 2 years on tobacco control. And I can't even begin to say how important that your unit, your school, is in trying to achieve that over the next couple of years.
And we've done so much on tobacco control in Hong Kong, but of course we know that there are other important risk factors, and the UN has named 5 risk factors, including, apart from tobacco use, alcohol use, unhealthy diet, physical inactivity, and then one environmental risk of air pollution. I mean, apart from tobacco, which one, if any, do you think Hong Kong should target at the most?
I think tobacco was, in a sense, there first. I think we realized a long time ago it was a single issue. Food is more complex, the environment is more complex. Here was a single issue with a product of absolutely unbelievable hazard and harm to people. So in a sense, it was the easiest to tackle first. So the tobacco control community has really led the way in understanding that we need the lawyers, we need the economic evidence, we need to look at trade treaties, we need to look at the whole gamut of how to bring this epidemic down. But I think the other people who are working, for example, with diabetes or with hypertension and some of the other risk factors and food and alcohol, I think they are very quickly coming on board and realizing that you cannot solve these problems just by health initiatives alone, that you have got to tackle the industry and look at them and engage with legislators and do the kinds of things that I've been describing. So in a sense, there's a huge catch-up process around the world going on at the moment, and publications are certainly coming out at the way the food industry has behaved and the alcohol industry. Very similar, almost identical tactics to the tobacco industry. So I think the whole span of non-communicable diseases are really there.
And indeed, the same companies, big companies behind this industry.
And it's not just the same companies, there's this extraordinary movement between them. And I might say, in and out of governments in many countries. You've got this sort of revolving door, it's called, effect, of people who are working within governments, who leave governments and go to very lucrative contracts with these particular industries and then advise them from the inside. And some companies, there's one organization, I thought, based in the United States, who goes around the world trying to stop governments putting up tobacco tax. And where do they hold their annual meeting? In the House of Lords in London. Absolutely unbelievable, the kind of influence that some of these companies have. And that's why we need a very concerted and unified approach on behalf of public health.
Judith, thanks again for your wisdom and sharing. Thank you.
Thank you very much. Thank you.
Thank you, Dr. McKay and Professor Ho. Please be seated. It's now time for the intermission. Audience may take the opportunity to visit our poster session in the foyer. Please feel free to exchange ideas with our research postgraduate student presenters. Thank you, and see you at 3:50 p.m. We will now proceed to the second lecture. The title of the lecture is Infectious Diseases, Hong Kong Public Health and Infectious Diseases. May I now invite Professor Leo Poon, Chair Professor of Public Health Virology and Head of Division of Public Health Laboratory Sciences, SPH, to share with us. Professor Poon, please.
Thank you so much in having me, and this is my pleasure to try to join this event and celebrate the 20th anniversary of public health, School of Public Health in Hong Kong. So today I'm going to talk about, actually I joined this university in 2001. So basically I witnessed the birth of this school, and then I'm also very glad to be involved in these activities to try to contribute to improve the health in Hong Kong. Now, maybe I should try to let you know that our team basically work on emerging infectious disease mostly. So the viruses that you have seen in here, okay, H5N1, SARS, pandemic H1N1, MERS, H7N9, and SARS-CoV-2. We have been gone through this long journey for the past 20-odd years. So we have been involved in this activity and try to use multidisciplinary approach to try to analyze these viruses using different models, analytical method, and so on and so forth, so that we can try to develop some evidence-based control measures to try to build a barrier so that these viruses cannot able to jump into human or minimize its impact to the public health. Of course, being worked in School of Public Health, we also try to work on human samples as well and try to analyze data. COVID-19 is one of the examples to try to, again, try to better understand the disease transmission dynamics and provide evidence to inform public health policy. And with our commitment in this, we have been working heavily, closely with FAO, OIE, and WHO, and we are the WHO reference lab for H5 and COVID-19. Right, now today I'm going to try to share some of the examples that we have learned in the past 20-odd years in dealing with this emergent infectious disease. Those studies were not necessarily conducted by me, but then my colleagues in the division or in the school. Right, now let me first start with this infectious disease 101, which I normally use for my first class in the MPH program. To understand the transmissions, we have to understand these 6 components so that we can able to develop control measures to break the transmission chain. And today I'm going to share some of the examples that we have learned through research and use laboratory data to try to develop control policy to control some of these diseases. Right. First of all, let's start with the infectious agent. Right. The most important thing is we need to find a way to detect the pathogens in the first place. Otherwise, this will be silent spreading among the community or within the regions, so that we cannot able to control it better. So we have been doing a lot of laboratory diagnostic tests, and dating back to 2003 when SARS came. So we have developing diagnostic tests for SARS, pandemic 1N1 in 2009, and H7N9, and so on and so forth. And all of these tests has been developed within weeks. And we share these reagents and protocol to various stakeholders almost in no time. The most recent one is the COVID-19. We developed the test in 2020, January, and within a few days, we share this protocol to WHO and share these assay and reagents to over the places. Just within a few months, we sent these reagents to over 77 countries and with 170 destinations. Some of these countries, like those highlighted in star, they are actually belongs to Pasteur network. They have been using my test to try to detect their first SARS-CoV-2 patients, right? So, I mean, the reason that I want to mention this is because it's so important to detect these pathogens. Otherwise, we would not know the disease burden. Right, and with these diagnostics tests, we can able to start to look at the patients and also its ecology. Right, this is one of the examples that we have done. Professor Pierres, he managed to find that SARS-CoV-2 can jump from human to pets. And later on, we also found that some of these patients can able to transmit the disease to hamster, to pet hamster. And in our studies, we managed to show that some of the imported hamster from Europe, they can able to spread the disease SARS-CoV-2 Delta variants into a community full of pet shops. And this actually all thanks to all the previous excellent work developed, established by these three great gentlemen, Ken Stockbridge, Malik Pierres, and Yi Guan. They actually advocate for the One Health concept for the past 20-odd years. And they have been conducting a lot of surveillance at the animal-human interface, like the avian influenza viruses in vet market, MIPO, wild bird, and swine influenza in slaughterhouse, and all the other animals virus surveillance in wild animals, right? So we have been doing a lot of interesting work, and not only that, we also try to do similar surveillance in human sector as well, right? And now talking about avian influenza virus, I'm sure you heard about this H5N1 for many years, and recently it has been even more worrying. You can see that H5N1 can be found in all continents, right? In North America, South America, Europe, Asia, and in addition to that, there were some human cases in different continents as well. So, but in Hong Kong, because of our long-term surveillance and our research work on avian influenza virus, there were no human cases for the past 20-odd years. That was because we have been doing a lot of systematic surveillance, and with this data, we can manage to try to inform the Hong Kong government and work with government together to try to develop new policy to control H5N1. And so that's explained why in the past 20-odd years, we have no local H5 human cases. And I just give you one example about the long-term surveillance of avian influenza virus in the vet market. So we have been conducting this day back to year 2000, and even up to now, we have been doing this surveillance almost every week. Right? We try to look at influenza activities in the vet market, and this is the result from H9N2 from 2000 and 2012. You can see that whenever we introduce new policy, the avian influenza activity has gone down and even almost to zero nowadays. So that explains how basic research can inform health policy and how we can able as a scientist to try to provide information to promote health. Right now, again, talk about H5N1. That actually is quite varying nowadays because not only these viruses has been found in different continents, but actually the transmission pattern seems to be very different. So this is the strain lineage 2.3.4.4b. This lineage is actually basically causing a problem nowadays. And you can see that for the other H5N1, other sublineages, most of these viruses can be found in domestic bird, basically poultry, chicken, duck. but for this particular lineage, 2.3.4.4b, and you can see that a lot of H5N1 could be found in wild bird, suggesting that the transmission dynamic of H5N1 could be very different from what we have perceived in the past. So again, that requires extra bit of work to understand the virus ecology, and so that we can able to develop a better policy to prevent human H5N1 infections in Hong Kong or beyond. Right now, talk about virus itself and how about its transmission. So I'm trying to, try to go back to this basic transmission cycle and try to use some of the examples that we have learned to try to illustrate how important it is to try to disrupt the transmissions. So right at the beginning of the pandemic, our colleagues, Dr. Yan, she managed to try to understand what control the transmission of SARS-CoV-2 in human. So is it due to contact transmissions, aerosol, or formal transmission? And she immediately tried to develop a hamster model to try to use different settings to try to demonstrate the transmissibility of SARS-CoV-2. And in her studies, in short, these all three transmission modes can be achieved viral infections. And that explains why mask wearing and social distancing are important for controlling SARS-CoV-2 in the community. And that is not happened overnight. In fact, my colleague, Dr. Yan, has been doing a lot of transmission using hamster, ferret, to understand influenza transmission before the COVID-19. So that basically tells us we need to invest on on science, to develop a platform to try to groom our next generation scientists so that we can able to use our technology to understand these novel disease in a timely manner. Of course, you can argue that, this is only an animal, and hamster transmission doesn't mean it can be replicated in human. And again, my colleague, Professor Ben Carling, he has been using these machines, which have been shown by David before. Basically, we managed to try to convince some of the infected individuals sit in front of the tunnel and allow them to watch a video for an hour or two, and then occasionally ask them to cough, to sneeze, and then we try to capture all the aerosol emitted by this patient and try to measure how much virus is being shed by these patients. Of course, at that time, that was not done using COVID-19 patient because there was no COVID-19 at that time. But he has been using other patients who have been infected by other human coronavirus, like OC43 and 229E. And this is the data that he demonstrated with a mask. Basically, he hardly can detect anything from the emitted droplet. But without a mask, then they can see that some aerosol, some droplets, can actually contain some infectious virus in it. So now that basically is another way of evidence to try to demonstrate mask wearing could be useful in reducing transmission of SARS-CoV-2. Right, now the other thing is once we have the virus, we know the transmissions and what is the risk to human. My colleague, Dr. Chen, he is so good in using human tissues to try to assess the risk of these different type of viruses. This is one example using influenza. This is an assessment tool for influenza. And there are many ways in assessing the risk, and one of them is basically receptor binding. He tried to use different human tissues like nasopharynx, bronchus, and lower lung, basically upper and lower respiratory tract tissues, and try to infect that with different type of influenza virus like H5N1 or other like pandemic H1N1 influenza virus, and try to find out how likely these viruses can able to replicate in these tissues. The higher its replication it is, the more likely that it may able to infect human and cause a lot of virus during the infections. So with these data and together with other data, we can able to do some risk assessment. So for example, H7N9 seems to be quite a dangerous virus. They may have a zoonotic potential and a high risk to human health. With this concept, he managed to use the same concept to try to assess the SARS-CoV-2. And you can see that this is the virus for SARS-CoV-2. And right at the beginning of the pandemic, he used the ancestral SARS-CoV-2 virus to try to infect different type of tissues, bronchus, lung, and conjunctivis. As a control, he used other viruses like SARS and MERS and so on and so forth. And what he can tell is actually SARS-CoV-2 is actually a very efficient virus in terms of infection in human. And it can replicate very well in all kinds of tissues. And in 2021, at the end of 2021, we managed to identify Omicron in one of our import cases. And immediately isolate this virus and we do the same risk assessment. And all in all, you can tell that Omicron replicates much faster than the ancestral virus. As shown in here, this is the purple bar is the Omicron. It replicates much better than the wild type, basically ancestral virus, and the Delta variant, right? And even worse, this virus actually grows much better at the upper respiratory tract at 33 degrees Celsius. So suggesting that the virus, the ancestral virus, is adapting in human, it becomes replicating much better, and that you'd like to replicate in a lower upper respiratory tract, right? Again, that will be verified by other tissue imaging, which I'm not going to elaborate a bit more, but basically we can use human tissues to try to do risk assessment on these emerging viruses. And without showing the details, my colleagues try to use the cutting-edge technology called organoids, respiratory organoids, to try to do similar risk assessment for some of the recent variants. Right now, the other risk assessment is how is the risk of the community? So how many of them will be infected? How likely they will be infected? Does the vaccine actually work? This is some of the examples that Professor Pierres have done. So you try to do a risk assessment on those individuals who have been vaccinated with 2 doses of messenger RNA, 3 doses of messenger RNA, or 2 doses of inactivated vaccine, 3 doses of inactivated vaccines, and then also 2 doses of inactivated vaccines followed by mRNA vaccines. And then he tried to collect the blood and try to find out how likely they can able to develop antibody against the ancestral virus and the Omicron. Right? You can see that basically, no matter what you have done, if you only visit inactivated vaccines, you actually do not have a good antibody titer against Omicron. But if you have received additional jabs of mRNA vaccines, the antibody titers go much better, right? Again, with this data, we basically send this message to the government and try to make a recommendation and say, for those who only receive inactivated vaccines, these people should be boosted by messenger RNA vaccines. So again, how science can inform public health policy. Right now, we are still sitting in this WHO Tech VE group. We basically still have a bi-weekly meetings, and we basically exchange idea, information, and try to find out whether the emerging variants have any major concern in the community. And this have been, we have been actively involved in the WHO and try to get the first-hand information around the globe. So the other thing that we have been, in this pandemic, I think is very eye-opening to me is the genomic surveillance. We were also involved in some of these activities, but this actually definitely will be the future for our public health, right? And in fact, WHO also tried to launch this different program for global genomic surveillance with different objectives, which I'm not going to talk about it, but please try to have a look on this website. They are providing information, and I believe this global genomic surveillance will be one of the key components of infectious disease control in future. Right, with this genomic surveillance study in Hong Kong, we managed to sequence a lot of patients and try to understand the genetic diversity, the viral genetic diversity among this population. We can manage to show many different types of interesting transmissions, like transmission in field of flight, zoonotic transmission or reverse zoonosis, reinfections, and transmission dynamic within the community. Right, but not only the science is interesting, but how we can able to apply these scientific facts to inform policy is also important. Right, for example, like this one is the genomic surveillance. This is the wave 3 and wave 4 of SARS-CoV-2, wave 3 and wave 4. And then we sequence some of them and try to understand the phylogenetic of these viruses in the Hong Kong community. And then we also managed to show that these control measures applied in different phases actually have different effects. To cut the story short, based on the phylogenetic, we can tell that the control measures from wave 4 is much more efficient than wave 3 and also much better than those applied in the wave 1 and wave 2. Right? that can, just by using sequencing data, can able to assess or evaluate the public health policy. How about predictions? Now, my colleague Vijay has been using this pharmacodynamic data to estimate how many people were infected in the wave 5 of SARS-CoV-2 in Hong Kong. And I hope you recall that at that time, a lot of people get infected and people start reporting their positive cases to the government. So we know that at that time, there are a lot of underreporting. And by using this pharmacodynamic data, my colleague Vijay, he managed to try to do the estimation using his model and predict and estimated that about 50% of the entire population in Hong Kong were infected by COVID-19 during that period of time. In fact, some serological surveillance data also use similar results, so indicating that the peak of this COVID-19 in the 5th wave is much, much bigger than we anticipated. Right, and my colleagues, Tommy Lam, and also try to develop another method to try to break down. I mean, we can measure the RT of SARS-CoV-2 in the community, but we don't know which variants actually affecting the community most. So what he did he tried to analyze the pharmacodynamic data and try to break down into different lineages, and then able to try to measure the RT of individual lineage, so that we can able to identify which lineage or which particular strain or variants actually playing the major role in the community. Right, now the other thing related to genomic surveillance is the sewage surveillance. And Maria Koopman have just mentioned about the importance of this sewage testing in community. In fact, we also did that in Hong Kong right at the beginning with the actually, it was led by Professor Zhang Tong from Faculty of Engineering. He managed to establish a system here and try to collect sewage samples in different manhole or sewage treatment plant so that we can able to identify individual buildings that may be positive for COVID-19. And this will trigger colleagues from the government to launch a community testing program, maybe just basically doing quarantine or testing for all the individual in particular buildings so that and get the result to be done overnight. And by the next day, the residents in this building can be released like for work or to school. Right now, this is one of the examples and showing that when we have a positive samples in sewage, we can trace back and able to identify the building and conduct community tests, and then able to identify a few individuals from the same buildings and then send them to a hospital and try to isolate them and prevent the subsequent transmission caused by these patients. Right, now the other thing is the wastewater genomic surveillance is not only detecting the disease or the pathogens, but we can able to try to do a much higher resolution analysis, like which variants actually circulating in the community. So this is one of the examples which published very recently. This is the different type of Omicron variants, BA.2.X and something like and BA4 and BA2. All right, you can see that in different regions in Hong Kong, we can able to tell that different variants are actually their circulation kinetics or dynamics could be different, right? That may help us to try to identify which region actually contain emerging variants or not. Right, and also be able to try to use the same technology for influenza surveillance, and that has been just published. Now, the other thing that I would like to highlight is the Hong Kong is actually an international travel hub. In fact, Hong Kong was considered to be the 10th connectivity index, top 10 in the connectivity index. So a lot of flight or passenger will get into Hong Kong either by transit or get into China. In fact, we have been testing a lot of patients able to identify a lot of introduction of SARS-CoV-2 variants into Hong Kong, and some of them actually able to spread into community. So right now, we are developing a computation model to try to develop a much better surveillance system at the global level. So for example, which of the travel hubs should be tested, how many people should be tested, at what frequency. So now we are working on that. Hopefully in the coming months, we can able to have a very good model to show you. Right now, I don't have too much time to talk about this, but I would like to tell you that we actually do a lot of immunological studies and have a lot of interesting findings, but I don't have time to tell you like the T-cell antibody response, but I want to tell you that we are still doing the work. Like my colleague, Ben Cowling, he's still doing a lot of cohort studies to try to collect sample either from the community or vaccinated cohort so that we can able to understand the T-cell and antibody response triggered by this vaccine or by infection. Right now, for the last few minutes, I just want to highlight some of the things that we are looking forward to. Right, I told you before that we are the WHO reference lab for influenza virus, and we are the WHO reference lab for COVID-19. Okay, for influenza, it covers most of the things like avian influenza, human influenza, and so on and so forth. But for COVID-19, it's only talk about SARS-CoV-2. So how about the other coronaviruses like MERS or other animal coronaviruses? So we really want to get involved in it and try to use science to inform public health. So I'm very glad to tell you that we have just been invited to join the WHO network for we call Coronavirus Network, COVID-NET. We just have this invitation a few days ago. We will join them and try to look for coronaviruses that include animal coronaviruses and other circulating human coronaviruses. COVID-19 is one of them. And the other initiative that we have been asking ourselves is how can we do better, right? How can we prepare for the next pandemic, right? We know that it's going to happen very soon, but we don't know when, why, and how it's going to happen. So in essence, you should try to work on this now. But we actually don't know which pathogen will be responsible for the next pandemic. Is it disease X, novel pathogens, or we emergent infectious, emergent ones? All right, and then what are the existing gaps in Hong Kong, and how can we able to fill up this gap? So with the support of our Jockey Club in Hong Kong, we have just going to establish an institute called Global Health Institutes. This is a tripartite institutions with HKU, University of Cambridge, and IVI. Right, this tripartite center is going to be hosted physically in Hong Kong with the experts coming from these institutes. Right, they will come here, sharing the same office and doing the lab work all together and to try to tackle the next pandemic. So what we want to achieve is we want to be better prepared for the next pandemic by using experts from academics, industrial, or and political sectors. And then we also want to translate our research into practice so that we can make better interventions. And finally, we also want to try to make the world safer by advancing access, equity, and affordability to critical control technology. So we want to develop better technology at an affordable manner and share this to all over the world. Right now, we have 6 major domains in this GHI. So that will involve epidemiology and pandemic preparedness, health economics and modeling, vaccine process development, vaccine platform development, and immunology. So you can see that some of them are actually we have been doing a long time, like basic research, and then also some of the diagnostic tests. We have been doing it. But one of the missing bit, I think, is the downstream application of this, in particular for vaccines. So we have some experimental vaccines that has been tested, that has been worked in the lab, but we are not so good in translating this into commercial use. Right, so the importance of this IVI is because they have been actually doing a lot of clinical trial in Hong Kong, in Asia, and also in other continents. And secondly, they can manage to produce these vaccines for commercial use in a small capacities. And they also able to engage major vaccine stakeholders, like production companies, so that they can translate the findings from the basic research to big pharma or vaccine company, and so that we can able to able to share our technology and new interesting control measures to the public in much quicker time. And most importantly, IVI is going to establish a small vaccine production plant in Hong Kong. So, which is very important. We believe this is a major gap in Hong Kong. We believe that we have a pandemic, a new pandemic. We may be able to use our technologies and our information and knowledge and able to generate some prototype vaccines for clinical trial, and also may be able to connect to the major pharma for vaccine productions for commercial use. Right, so at the end, I would like to thank my colleagues in School of Public Health and also my colleagues in other departments of HKU. And most importantly, I would like to thank all the governmental departments. I mean, you can see that in some of the example, we have to work with animals, we have worked with patients, and we have sometimes work with wastewater. So, I mean, without the support from the governmental departments, it would not be possible. I think I will advocate that for controlling infectious disease is not only one of these departments or one of these academic institutes can able to solve the problem. We all has to work as a team to try to cope with the next. Right, and I would like to thank the funders and those providing financial support to us. Right, thank you very much. Together we achieve more. Thank you.
Thank you, Professor Poon, for your sharing. Please be seated on stage. We will now proceed to the Q&A session. Audience can make use of the QR code to pose your question. Professor Hui-Ling Yan, Associate Professor of SPH, will be moderating the Q&A session. May I now invite Professor Yan to the stage, please.
Thank you very much, Leo, for sharing the experiences and wonderful lecture. So we have learned a lot since you joined Hong Kong U in 2001 through the outbreaks of SARS-1 and also H5N1, H7N9. So that has prepared us to respond better for the 2019 COVID pandemic. So from your perspective, what have we learned in the COVID pandemic that can enable us to better prepare for the next one?
I think what have been learned that basically is how to work with other people, right? And the issue that most of the time, some of this information are not being able to disseminate in a proper channel. And there are a lot of misunderstanding, and some of this information cannot be released to the relevant stakeholder. So how we can able to build a platform and trust to have multiple entities work together is something that I think we should try to work on, like science communications. And the other things is, the other things that we have to focus on as a scientist is the capacity, right? Work capacity and next generation scientists. How we can able to groom the next generation to work together and engage them to work on this interesting field, right? So I think that will be very important.
Thank you, Leo. So I think we have some questions. So we have a question saying that, may I ask why Hong Kong would benefit from a vaccine center?
Right now, we actually do not manage to produce vaccines and produce local vaccines for use, right? And this is one of the gaps. And now, right now, Hong Kong government and mainland government talk about these tech transfer innovations. So I think we have the capacity in doing excellent academic research, and we have the capacity and actually doing some experimental vaccine studies. So it will be very good to try to use this vaccine center to try to produce some experimental vaccines for clinical trial and within the GPA or beyond. So I think just like the COVID-19, when we have the vaccines, actually we need other countries to make the vaccines, other countries to try to provide evidence for us, before we can able to use it, right? But if we can able to produce our own vaccines and do our own clinical trial and evaluate the data, and we can have a much robust mechanism to try to protect our own citizens.
Yes, there's another question. As a scientist, what's your experience working with government during the pandemics, and how would you advise to other scientists when working with them?
This is an excellent question. Now, I think they have been fantastic. So because everyone here at that time actually know very little about it, and they want to have information. So they're actually, we can capture information. And I think what we need to do, right, for work to build a relationship with this government is, number one, and this is based on my own experiences, number one, be transparent. And number two, they don't want to have surprise. So if you have information, you really want to let them know in advance before you talk to like the public, to the press, and so that they can able to try to act before the public know about it. So I think this, again, reiterate the importance of having a robust interaction and transparent communication between both parties, right? And now, but when the pandemic come down, then it's hard to find a way to maintain this communication because everyone go back to their own business. So how we can maintain this interaction is important. I think more frequent dialogue will be important.
Great. So I think our session is finished. Thank you so much, Leo, for sharing your wisdom.
Thank you, Professor Poon and Professor Yan. Please be seated. We will now proceed to the plenary session on primary health care. Our first speaker is Professor Sophia Chan, Professor in Nursing of Lee Ka-shing Faculty of Medicine. The topic of our presentation is the PHC Blueprint and Origins. May I now invite Professor Chan to the stage, please.
Thank you. Good afternoon, and thank you, David, for inviting me to this 20th anniversary conference. Being a graduate, PhD graduate of this School of Public Health, at the time it was the Department of Community Medicine, more than 20 years ago, I'm really pleased to see all the achievements of the school, and congratulations, David. So pleasantries aside, coming back to primary health care. So I was asked to talk about primary health care blueprint and its origins. Of course, the next speaker, Dr. Pang Fei Zhou, is obviously the current commissioner, is going to talk more about what is happening now. But I would like to not only talk about what happened of the origin of the blueprint of the Hong Kong government during the time when I was in the government, but going back to the global level as well. So, primary health care is not new. In 1978, the Alma Ata Declaration already talked about primary health care. And then in 2018, there was another, 2008, there was another report on primary health care more than ever, that it is essential care, universally accessible, and the focus is really about people's participation and self-reliance and self-determination. Of course, WHO also want everybody to come together, especially the governments, to embrace, primary health care. So in further on, 2018, Astana Conference also have a renewal of commitment to primary health care. And at that point, universal coverage, sustainable development goals, these concepts, came into play as well. How about China? So mainland China, in their Healthy China 2030, also embrace primary health care in China that can play a valuable role in the prevention and also management of chronic disease. So again, going into family medicine and training GPs and going into the community. So how about Hong Kong? Have Hong Kong done anything? Of course. So since the Alma Ata 1978 declaration, so Hong Kong has done this report, this report in 1990, where Professor Rosie Young, who is here in the audience, is the chairman of the working party on this primary healthcare report called Health for All: The Way Ahead, and the report of the primary healthcare. So I don't know whether people know the former chief executive, Mrs. Carrie Lam, was the secretary of this report, working closely with Professor Rosie Young. Of course, you saw all these reports, by the government. Not all of them are on primary health care. But one thing the government knows that is not going to be sustainable if we are to continue, this very heavily subsidized secondary and tertiary system without a primary care system. So the key recommendations, of course, is a strong emphasis towards primary health care in the policy making and also primary care services, with the context of aging population and also growing burden of complexity of chronic diseases. So the current system is not going to be sustainable. Of course, we know, for those of us who are in public health, we all know about the inverted triangle in terms of funding and the reality. So the reality is lots of resources are given to secondary and tertiary care, while lots of people are actually, needing primary health care. So during 2017, so we actually came up, the chief executive is strongly supporting primary health care, and so we set up a steering committee on primary health care development in the government. We developed 18 district health centers, and the mandate is within the 5-year term of government, we have to do all these. And also we completed a blueprint for development of primary health care services. So a number of people here are also have done a lot in terms of the steering committee. So these are some of the milestones if you talk about origins of starting this reform new journey. So the chief executive fully support, set up steering committee, and also in the bureau, we set up the primary care office under the Food and Health Bureau. Now it turned into the Commission of Primary Health Care. And of course, very sadly, we had a COVID, so it should have been, even working even faster if we don't have COVID. So in 2022, the chief executive, after getting all the district health center in place, announced a new journey of primary health care. So these are the 18 districts where we have primary health care. So the blueprint, there are 5 focuses, 5 areas, and I'm not going to go into it because I know, Dr. Pang Fei Zhao is going to, let you know the latest about it. But if you look at the 5 areas, they are all policy tools, such as building a system, setting up governance, having consolidate the existing resources in primary healthcare, reinforcing manpower, of course, training, education, as well as, most importantly, personally, I think, is data. So data connectivity and health surveillance. So finally, my 6 minutes is up. The take-home message is really primary healthcare provides the ultimate solution given the context, and more sustainable healthcare system. So we have, during the 5 years while I was in government, we set up, the infrastructure, some foundation, but now, of course, we understand this term of government is very supportive and is to take over and, implement, all the work in the blueprint, which is very, very important. So, I hope, all of you would embrace it. And also, we look forward to the next speaker, Dr. Pang, to tell us a little bit more about his vision. And also, in talking about Dr. Pang's vision, please remember to take a copy of this primary healthcare inaugural newsletter of the Primary Healthcare Academy, which is set up in the University of Hong Kong, because we have Dr. Pang Fei Zhao's inaugural interview that would tell you more vision, or more of his vision as well. So thank you very much.
Thank you, Professor Chan, for your sharing. Our second speaker is Dr. Fei Xiaopeng, Commissioner for Primary Healthcare of the Primary Healthcare Office Health Bureau, the HKSAR government, President of the Hong Kong College of Community Medicine. He will share with us on the topic, Current Issues in Primary Healthcare in Hong Kong, from Blueprint to Implementation. Dr. Pang, please.
Thank you very much. Thank you, Professor Sophia Chen. I think under her guidance, the Blueprint was born in 2022. The topic today assigned by Professor Bishar and asked me to say what's the current issues in the primary healthcare in Hong Kong from Blueprint to implementation. Because in the past, yes, we discussed a lot of papers. For me, I think I really need to think how I can implement it. The first thing is I need to read all the reports and find any secrets in the report so I can have some idea what I should go. Basically, I presented this PowerPoint the year before because this is secret. I think I did find it, and the last time we implement the pilot, and I think this is the really need the key point for us to work on. That's the change from the top down to bottom up. The health must belong to every one of you instead of we try to drive health from the government alone. So you can see the name of report is still change from the top down view for all and then go down to our partner. So in the same time in China, everyone also mentioned that health is you are the first one to account for. This is really true for Chinese or in Hong Kong probably also, because in Hong Kong, many people during the fifth COVID, we cannot differentiate Panadol and paracetamol because we think that the professionals will support us whenever we get ill. But we forget the health. Basically, we need to work on and spend more time and effort and also even the money to do that. Otherwise, you always relied on others to tell you, then it may not have the best option for you. So prevention will be the difficult part for every one of us. Yesterday, we discussed the oral health for adolescents. I think this is even harder because in Hong Kong, we may be very famous for poor oral health, but we don't know about it, so this will be another challenge. So this is 5 focus areas Professor Chen mentioned. I think every word we know, but how we can do it is really a problem. Because in Hong Kong, we have a lot of providers in the community, but why we need to develop community health system? And we did have Department of Health, why we still need to strengthen the governance, and also what's the problem with training, and also what's the problem with data connectivity. So all those questions are in mind, and the government, of course, is very good to set up 2 organizations. One is called Primary Healthcare Commission, and the other one is the Strategic Purchasing Office. So I think the government think the job has been done, and because this is the 2 agents we would need to go for. So what's in my mind is to try to test the system. So this is pilot program we implemented last year in November of last year. You can see every one of them hold a plate. That plate means that I would like to test seven things, whether it really works and what's the challenge. Include the family doctors, district health center, primary care directory, and e-health, and also whether we can have a health plan and so on. So I really find that there are lots of problems in Hong Kong in family doctors because they don't know what's the role, and the district health center, we don't know what they can connect, and the e-health, we need really know how can they empower patients, whether people accept the co-payment, and also what's the nurse can do, and also what's the interaction between the primary and secondary care. So for implementation, I think there are a lot of questions in mind. I put a lot of reset, redefine, review, revisit, redesign, rebuild. But although everything is real, that means that exists. We just need to rethink and see whether we can build a connection between them. So quality assurance is critically important because in Hong Kong, we trust more public, the system, than private because still there are some worry about the charging and fees and charging in the private. But we also have the problem of fees and charging the public. So in the coming year, we have a lot of discussion how we can change the behavior of our public in using the co-payment as well as the subsidization and the incentive. And also we need to have a legal framework like direct access of PT, physiotherapy, that really involve the primary care a lot. So to build up the protocol-driven system and also the family doctor system. And the e-health really need to enable the connection. So we try this and we feel we have confidence because in the last 2 months, we have over 20,000 people join the pilot program, enrolled in the pilot. And also we have 30% of those who complete the screening had the pre-diabetes, diabetes and hypertension. So it's really a lot at the moment. We hope that this percentage really bring up the awareness of the people. So what are the issues is of course, what are the fees and charges? What's the proportion of funding that's spent in the primary? Second is what's the common goals of professionals so that we can work together? And third is what's the new statutory function of the Primary Health Commission? It's not Blueprint, it's Commission, so that we can enable those things happen. And the acceptance and affordability of general public, that they are willing to have the co-payment for the healthcare, which we have tested in the pilot program of chronic disease care. People really did willing to pay about $200 for everything for them. So whether it's with a good start, and also the user experience on the e-health application, which we did encounter a lot of comments and complaints from the professionals when they use e-health, but we need to spend a lot of effort on that. Lastly is how can district health center connect with mental health, oral health, and exercise prescription, and also elderly health, women's health, all those things, how can it happen in the district health center? So those things are the issue, I think, really is a long journey. So don't expect too much, but we can work step by step towards the establishment of primary health care. Thank you very much.
Thank you, Dr. Pang, for your sharing. Our third speaker is Dr. Luis Bernal, Professor of the School of Medicine and Health Sciences, Rosario University in Bogota, Colombia. He will talk about global opportunities in primary healthcare. Dr. Bernal, please.
Okay, thank you very much, Professor David, for the invitation. It's an honor for me to be here in this celebration. So, global opportunities in primary healthcare arise as a response to current global challenges and goals in health, such as demographic and epidemiologic transition, the negative effects of social determinants of health, health disparities, and health inequities that particularly affect socially deprived populations, limited accessibility, comprehensiveness, and coordination of healthcare, shortage of and uneven distribution of health workers, and of course, the goal to achieve health-related SDGs, universal health coverage, and health system sustainability. So, at the policy level, there are many opportunities, especially in low and middle-income countries, to strengthen national health policies with comprehensive primary health care, with robust benefit packages with a high number of preventive and promotive activities, ensuring equity access not only to essential but a full range of health services that are amenable to address at the first contact with the health system, including multi-sectoral policy and action to really positively impact the social determinants of health, involving the community to track the actions, to account the activities in charge by on the health leaderships, and also to empower them to make the healthy decisions. And also policies that promote health conducive environments to facilitate the healthy lifestyles. So there are opportunities to invest more and better in primary health care, shifting from input-based to population-based funding arrangements, which implies empanelment to really know the population to be served, a prioritization of public funding of PHE with standard risk pooling and prepayments, with revenue mechanisms based on ability to pay in a progressive way, elimination of user fees and reduction of out-of-pocket expenditure as main barriers to access services, rethinking the role of development assistance that should be focused particularly in low-income countries, and not only in specific programs, but in the strengthening of the full PHC system, and to ensure allocation of resources based on individual characteristics and financial management mechanisms to ensure that the resources come to the front line with the right incentives for providers who really invest and deploy activities and actions to maintain the health of the population. There are opportunities in service delivery and PHC management. Primary care networks are a good example how to organize better the services, public and private health facilities, to make more efficient the service delivery and the use of the available resources. Innovations in models of care, transitioning from disease-driven to salutogenic models of care with a family and community health orientation, with integration of public health and primary care activities and health personnel, so the essential primary care services and the essential foundations of public health together with traditional practitioners as well, delivering culturally appropriate services in a participatory way and in a proactive way, with strong gatekeeping activities to make the systems more efficient and to be able to resolve up to 90% of the common problems from PHC. Increasing the accessibility to health technologies to track the patients, to make them more empowered, and also to use the technology to produce data that we can interpret, analyze, and use to make better decisions. And finally, there are opportunities to strengthen PHC workforce training and development, making consensus on the core curriculum of the present and future health personnel in PHC, decentralizing the education to increase accessibility, especially in rural areas, training in rural health, exposing early in the academic programs of health professions to students to PHC, which is something that highly impact the future decisions on working in this field, increasing the recognition of general practitioners, other occupations in PHC, even the caregivers and volunteers to become more trusted and reliable for the society, adjusting the financial resources, the packages, compensation packages for those who work in PHC for make more attractive to be in this field, and cooperating more across states to manage the health workers' migration, innovating in ways to retain the health personnel where they are most needed, and finally producing data and research in the way how we can improve the training and management of the health personnel, the health workforce for PHC. So I stop here, and we hope to have a great discussion now. Thanks.
Thank you, Dr. Brunel, for your sharing. Please remain on the stage. We will now proceed to the plenary and Q&A session. Audience can scan the QR code to pose your questions. Professor David Bashai, Director of SPH, will be hosting the plenary and Q&A session. May I now invite Professor Bashai, Professor Chan, and Dr. Pang to the stage for the session, please.
Well, thank you so much for leading off our plenary session with your insightful comments. And this is part, past, present, and future of public health in Hong Kong. And we really do need to look ahead to the future of how School of Public Health and the broad community can get involved. So I have some questions here. Please feel free to add questions, but I'd like to start with that question. How can communities and the academic institutions play a role in supporting what we want to do in the future?
Thank you. I have the mic with me, so I will start. First of all, I think the government have tried to lay out in the blueprint 5 very key areas. And these areas are not something that is just put into the blueprint. So that was with a lot of data analysis, a lot of looking at the local context. So I think some of these issues in the blueprint, if you are depending on whether you are from the university or whether you are in the practice. So I think everyone will have a role. For the university, David, I think as far as the blueprint is concerned, training, education, capacity building, as well as building evidence-based primary healthcare model is very important. Of course, I think data connectivity, which I understand is very dear to your heart as well. If we are to do, if we are to really come up seriously with a primary healthcare system, the data from primary, secondary, and tertiary must be connected. And that way we can not only capture all the data, but also can do health surveillance. So I think these are some of the things that come into my mind.
Well, from the side of the community, I think the more we involve communities in the way the health services and the policies are built and delivered, the more the community will be part of this process. They will be in charge of the accountability activities, exerting pressure and demanding from the policymakers and those who deploy activities and PHC services what the population really need. So it's important to involve them from the beginning of the process of the implementation, as I guess the Hong Kong state is doing. And this implies build capacities in them, leaderships, and health literacy is very important. There are some roles that are played by specific profiles of health personnel. Just came to my mind the community health workers. This is a very good way to engage with communities. They are part of the communities. They are taught on the basics of the PHE and how they can serve as a bridge connection between those who make decisions, those who deliver the services, and how these activities really target the benefit populations. And it's also a way to receive feedback from the population, how, to what extent these activities have been impactful.
Agree totally with 2 speakers. In my experience in the last year, I feel that Hong Kong basically had a lot of providers. The problem to me is the role delineation among different providers are really confused. So the family doctors don't know they need to give vaccination, the vaccinated people, and district health centers find it difficult to connect with other NGO. And some themes, like the population, they don't know where they can get the data or information to connect with those services. So I think, firstly, is how can we have more role delineations? I think legislation help because like PT direct access, community pharmacist programs, they really provide some role delineation. And also if we can provide the family doctors what's the role they need to take up in the whole prevention, that would be helpful. And then in the apart from legislation things, I think funding is important, how to incentivize to go to do the role they are assigned. And then afterwards, we need to build the, I think in the sense of the networking in the district. because at the moment in each district there's no formal network. I think in the electronic world, in the e-health world in the future when we develop, we try to build a connected health providers network, either voluntary or district center lead, and then basically try to drive them to form some sort of services that are available to the people in the community. Yeah.
So I'm going to read about 2 or 3 questions and put them out there for you. And then if you listen closely, you can come back and address them. So we'll have them circulating. So one question is, how do we address the misuse of public accident and emergency services in Hong Kong? I guess there's some overuse. That's one question. Another, how can primary health care solve the health inequity in Hong Kong? And third, what kind of data should we be collecting to support primary health care? So anyone want to tackle some or all of those questions? Go ahead, Luis.
Well, primary healthcare is a very good driver to close gaps in terms of health inequity. Because as we include the population and they have the same right to access health services, there are clear portfolio of health maintenance services, and those reactive services, if I can call them that way, when the disease is present. So everyone to be able to benefit from these services, no matter what ethnicity group they belong or the wealthy quintile they belong. So primary health care itself, based in the foundations, it's a very good driver to close equity gaps.
Okay, so the accident and emergency, the misuse, yes. So the government is already blowing wind about increase in price in the accident and emergency department. Use the public accident emergency department. I think this is one way forward. Personally, I agree with this approach because the government has long been putting in or subsidizing secondary and tertiary care. So I think it's time that the price is adjusted so that the health-seeking behavior can somewhat be changed or be influenced. Secondly, I think we obviously wanted to have a good primary healthcare system in place. So not only a project or a center, but really a system. Because once we have the system, then I think people can find the services that they need in the community. They have this one person, one family doctor system. If it is in place well, then the health-seeking behavior can be changed, and then ultimately the A&E department use would be adjusted. It would not change overnight, I don't think, but it would be changed. Second, about the data, the question about data, what kind of data? I think first of all is a population-based health data. It is important that we know, or the government know, that for each district, what is the health status of the people. Currently, the Department of Health is doing health behavior survey and different kinds of survey. So if we have the data connected, then if we press one button, it would be easier to do health surveillance. It would be easier to evaluate the healthcare services, the interventions, and to see if what kind of resources or what kind of interventions the government should play out in order to improve the health of the community.
Yes, for the Hong Kong, we asked a question whether people have difficulty in seeing doctors. Basically, this is a question. But we think yes, although many people don't agree, because the inequity is too huge, and some people may not aware that basically a group of people really find seeing doctors as very difficult issues. So this time, as Professor Chen said, the government tried to look at the fees and charge of the public system, not only at the A&E, basically it's all overall approach. So it's not just single fees in charge, it's overall how we can change the behavior of the public from primary care and then the A&E as well as secondary care. So another thing is the data-wise. For Hong Kong, I think people really want to know his own health data, but basically if you look at your eHealth app, there's not much. So what we try to work on is that basically everyone, they should have their immunization record, they should have their medication, they have their appointment, they have their family doctor system inside, and whether they can connect someone, they really look, want them to look after them. So the one health, one account, health account is very important to drive for the primary care. So that's all together, so we can see this is the overall approach instead of single approach. That would be better.
Okay, more questions. I'll be having you listen closely because I'm going to give you 3 questions next. How can eHealth improve mental health among subgroups like LGBTQ? Is conducting research and the research teams, are they welcomed in primary healthcare centers? And how can we encourage medical students to join primary healthcare?
Well, as I said in my presentation, there is evidence showing that as early the medical students are exposed to primary healthcare scenarios and big components of the curricular are based in primary healthcare, there are higher chances of medical students to become future work in primary healthcare. So exposure is very important. So if you don't know something, it is very unlikely that you select to do work in that field.
I think for mental health is the question is in Hong Kong, if in district there's no model at the moment so that we can do mental health assessment for many people. So many programs are very you can see piecemeal and not coordinate in the systematic approach. Apart from those programs already implemented at a high level, so. I think at the moment, firstly, is whether we have a good model so that we can combine the district-based service with the professionals that really can deliver the mental health intervention. And we should not just rely on psychiatrists to work on mental health. So another part is whether we can have some sort of technology-based things to allow the young people to use. For the time being, I still think the students, they can really work together to see what kind of the technology or things they among themselves, they really can motivate the people to enjoy, to participate and involve. Because I find it's very difficult at the moment to interact with the young people because they have their own work and we cannot decide something for them, but they really have something at work among themselves. So what are the tools that really can apply? So to involve them, I think students, university students really need to do something for secondary student, and secondary student need to do something for primary care student, primary student. So they need to develop the tools for themselves, and then we can try to make use of that tools to apply in the community network so that it can be more applicable. I think this is something I'm trying to work on.
Okay, so I want to address the issue of whether research teams can work in district health center. Of course, I can't say, and maybe Fei Zhao can actually talk a bit more about the work of the district health center. But research is very important, I think, especially at this point in time where the government is embarking on this new primary healthcare journey. We need more evidence, especially successful, effective primary healthcare models in the community. Hong Kong has long been very secondary and tertiary focused, and we are all trained in such a way that we work in hospitals. So as healthcare professional, many of us know how to work in hospital, the clinical area. But if you want to work in the community, you need a different skill set in addition to your profession. So addressing the medical students, how they can join, primary health care, I think not only medical students, but other healthcare professional students as well, including pharmacists, nursing, dental, Chinese medicine, etc., because it is a multidisciplinary team that must work together, in the community or in primary health care. So I think first and foremost, in the curriculum, I think there should be at least, a significant focus on primary health care, because this is what the government is, taking forward. Second, not only the knowledge, but also practice. So I think they should really go have some clinical practice, not only in hospital again. They should go to, for example, district health centers or NGOs or the community that actually run these prevention, health promotion, be it primary, secondary, and tertiary programs.
Just want to add, based on what Dr. Pang was mentioning about how the technology and health could help in mental health. In Colombia, there are many places in which there are no psychiatrists, not mental health professionals, but physicians, nurses, and community health workers have been taught in the mental health gap strategy. And technology is put in places so they can follow steps of this strategy in a electronic format, and outputs have been generated once they enter the information, and they are able to connect with mental health professionals remotely to make decisions when it is required. Otherwise, they manage the mental health issues by themselves. But of course, they are well trained in the initiative. So this is a way to use technology and also address these problems with not enough specialists in this field.
Thank you. We have time for one more question, and this would be a more integrating question. It really draws on all of our afternoon. It draws on Marion Koopman's speech about how One Health approaches are necessary in the emergence of infectious diseases. It deals with commercial determinants and tobacco, and it really also deals with infectious disease transmission. And the question is simple. It is, what is your view towards social determinants of health and commercial determinants of health, which tie closely to primary health care? What's the relevance of primary health care against commercial and social determinants of health, and how can we integrate that?
Okay, good. I like this question. So first of all, I think we learned from Judith this afternoon about the tobacco control tactics, which is quite prominent, in commercial determinants of health. Of course, there are many others as well. For example, milk formula company against breastfeeding. There are also, sugar. Whether we should have sugar tax, whether there is a reduction of salt and sugar, and all these non-communicable disease prevention stuff are really, really something that is very close to primary health care. First of all, I think if we are to educate the public, in fact, if you really go into the community, especially the very underprivileged, many of them do not really understand, the importance of, having a low salt diet, low fat, and all that, because, this is not something that they are having, every day. And some of these things are very, very expensive. So therefore, I think in primary healthcare, education actually play a very important role in all these commercial determinants of health and social determinants of health. And especially for commercial determinants of health, I think all the primary healthcare workers must learn and must know, the these tactics so that they become advocates of the commercial determinants of health as well?
Well, I am in agreement. People who work in primary health care must be educators. So we are in first touch with the population. We need to give them tools, information for them to analyze, to reflect on the effects of the commercialization of these products, how they can take control over the decisions they make. So this is perhaps the advantage of the primary health care, that we people who work in primary health care are very close to the population, so we can directly have impact on the decisions they make and how to advocate, as Professor Sophia mentioned, against this type of commercialization.
Thank you for this question. I think this question is really difficult and hard. When we're talking, one side we really worry about over medicalization. That means everything is medicalized. I need to see doctors. And the other side, you find that the social sector, they would like to lead something, and commercial sector want to mislead you something maybe. The issue is how can we focus like health as the key drive. Sometimes, although when we talk with social worker, they say, oh, we are talking about social medical collaboration. And then I share, oh, we are talking about medical social collaboration. So what's the issues that we can share in common, and then we can work together at least with some projects or in some starting point? Because I think health is just a description, but whether we can start with something and then we work together, because it's really difficult to argue who lead the things. So I think it's an interesting question, but I really want to see something that can happen in Hong Kong, like to me, like end of life. It's really good social medical collaboration or medical social collaboration, or something like because the health, the students' health is very difficult to change their behavior, while social workers may be very expertise in change their behavior. So something really, some profession are really good at, but really need to find out what's the projects or what's the things that it can work on, instead of a general speaking on certain determinants. Otherwise, it becomes an argument, a very philosophical level. Yeah, that's all.
Mm-hmm. One last comment, go ahead.
It is very important that health workers in primary health care have core training in public health and primary health care, because this way they really could feel that they are in charge and they are the implementers of this type of strategy, and not just waiting that someone else does this for them. So,
thank you. Okay.
Just one last comment. In looking at social or commercial determinants of health, I think it is important to put health in the center, but the collaborators would have to be multi-sectorial, because if we look at social determinants or commercial determinants, not everything comes from health. For example, if we want to increase tobacco tax, it is not under the jurisdiction of the health minister. It is under the finance minister. So therefore, it is very important for all the sectors to work together.
While I have you there, dinner's coming soon, and I want you all to know that your dinner will be safer tonight thanks to Sophia. Could you announce the trans fat change that has happened in Hong Kong? Go ahead and let us know more about how come dinner will be safer tonight.
No, so we during I think in 2021 we managed to ban trans fat quietly. We passed the law. And so thanks to Dr. Edwin Cho, who is at the time, the Commissioner for Center on Food Safety. And he done a brilliant job. And so we didn't make while the industry should scream, as Judith said, but maybe it's during COVID time, they are too busy. So we managed to pass the law, and give them a very long commencement date. So starting from December last year, so the law has actually been commenced, and so Transvet is banned in Hong Kong.
Thank you.
But actually not many people know. So I think this is a major achievement of public health, and thanks to the Center for Food Safety.
Thank you, Professor Chan, Dr. Pang, Dr. Brunel, and Professor Pajai. Please be seated. To celebrate our 20th anniversary, the school has conducted a mascot nicknaming competition, inviting our students, alumni, and staff to give our mascot a nickname in English and Chinese. We will now proceed to announce the winners of the Mascot Nicknaming Competition Award. The winning entry for the English name is Vitalis. The winner is Ms. Chow Yim Sao, Master of Public Health student. The winning entry for the Chinese name is Wai Wai, and the winner is Ms. Dion Chan, former colleague of SPH. May I now invite Professor Bishai and the winners to come on stage for the award presentation, please. Congratulations to all the winners. We will now present the Best Student Poster Award. The winner of the Best Student Poster Award goes to Ms. Guo Bingqing Dorothy. Please come to the stage for the award presentation. Congratulations to Dorothy. May I now invite Professor Bishai to give us the closing remarks. Professor Bishai, please.
Well, I am so glad that we had you all here to help us with our 20th anniversary. This was a fabulous afternoon for me. This is actually my second public health forum. I was privileged enough to see one at the end of 2023 in September. And at that time, it was such an introduction to the work of the school, and we were deciding whether or not we should actually make the move over. But just seeing all of the work last September of 22 really convinced us that this was the place. And coming here in January of 24, I'm just so much more thrilled to be able to join the school and see that the work we've done in the past and present and future is so strong. So an afternoon like this is something that has taken a lot of effort from our staff, and I really have seen so many planning meetings, so many staff are here working on their Saturday to come and host us, and it really is something that we do need to recognize. So I want to first give a round of applause to our organizers, Ms. Karen Ma, and all of the staff that you've seen today who have helped to organize, Melody and others. I can't name them all. Yankee right here. Everybody's working so hard on their Saturday, and we couldn't do it without them. And then we also have so many work of our faculty who worked so hard to organize the posters, the students for preparing the posters, the judges. I don't know how difficult that must have been for all the judges because there were some really excellent posters. So our organizers of the student competition, Dr. Nancy Lung and Mark Zanin, are you here? Could you stand so we could recognize the work you did to organize that? Thank you so much. Thank you, Mark. Thank you, Nancy, for that. And then for the judges who made that very difficult choice, could I ask to stand Professor Julie Liao, Professor Daniel Ho, Professor Sheikh Taslim Ali, Professor Chao Kwan, Youngwon Kim, and Maria Zhu. Could you stand so we could give you our appreciation? Thank you, judges. Thanks so much for all of that. So The presentations today, all afternoon, and your participation really have shown us why our school is making a difference every day in Hong Kong and how we support each other in our collective work. I'm so glad that students came. To see the students here presenting was excellent. So as I wrap up, I wanted our alumni to be especially recognized. Alumni, could you please stand for me? Let me see our alumni. Anybody who's gotten their degree at Hong Kong U? There you all are. Look at all of our alumni. Thank you so much for coming. Well, you have a special duty after we close. I want the alumni not to leave. Everyone else can be dismissed, but alumni, please stay for just another minute so we can get an alumni photograph. I'd like you to come up and we could get your picture for us. It's been a great afternoon. I won't keep you here any longer. You can go off to have a healthy dinner tonight with no trans fats and no tobacco. Okay? Thank you so much.
Thank you, Professor Bashai. Please be seated. This is the end of today's program. On behalf of the school, I would like to express our appreciation for you joining us today. We hope you have taken home inspirations and food for thoughts for the past, present, and future of public health. If you would like to take the shuttle bus to the Kennedy Town MTR station, please make your way to the main entrance of 5 Sassoon Road, the Jockey Club building for interdisciplinary research before 5:30 to catch the ride. Our staff will show you the way. Thank you once again for participating in our forum. Have a pleasant day. Goodbye. Alumni, please come forward to the stage for a photo.